So hello again, dear everyone. Now we will be discussing the final part of cardiac amyloidosis, which is the treatment. So as we said previously, you all know in the first lecture, we discussed the pathophysiology of cardiac amyloidosis. Our liver produces normal transthyretin in the form of a tetramer. The tetramer is composed of four monomers. Destabilization or instability of this tetramer is the disease, and the disease leads to separation or breakage of this tetramer to four monomers. Those monomers aggregate together to form the amyloid fibril, and the amyloid fibril deposits in the organs, causing the organ damage. In the diagnosis, we focused upon clinical symptoms and signs that represent a red flag, and we carried them on the word hidden, HIDDEN. And if you get those red flags, you will go to the flow chart. The first step of the flow chart is making a hematological test, including a blood and a urine test. If you detect the light chains, the AL type amyloidosis will be diagnosed. Refer the patient to hematologist to take chemotherapy, perform a bone marrow transplantation, because those patients will die within 6 months to 1 year. If the patient is suspected to be amyloidosis and he's not the AL type, you will go on with the flow chart. The next step will be a radionuclide scan. The radionuclide scan depends upon injecting technetium, and you will see one of four options. The idea is comparing the heart to the bone. So either the heart did not take any technetium, the heart took technetium less than the bone, the heart took technetium equal to the bone, and the fourth and the last option is the heart took technetium more than the bone. If the heart did not take any technetium, then there's nothing deposited in the heart, there is no cardiac amyloidosis. If the heart takes technetium equivalent to the bone or more than the bone, then it is grade 2 or grade 3. You are definitive cardiac amyloidosis. The only gray zone is grade 1. And in this grade 1, the heart takes technetium less than the bone. And this is the gray zone. You will need a further step, which is the biopsy. Let's say that you diagnose the patient now as cardiac amyloidosis, and you need to treat the patient. Do we have a treatment option available now? In Egypt, yes, we do. We have the tafamidis, or what we know as the Vendamax. So the tafamidis was originally a medication that has been found for several years, and this medication used to treat the patients with amyloid peripheral neuropathy. The small dose of tafamidis, the 20 milligrams, was used for those patients with peripheral neuropathy, and it causes symptomatic improvement in those patients because it led to stabilization of the tetramers of the transthyretin by a substantial percentage. So in those cases, tafamidis 20 was very well functioning. For the cardiac trial, the TTCR, and the long-term extension trial, we used the higher dose, the 80 milligrams. Why did we use the 80 milligrams? Because it leads to more stabilization of the tetramers. More than 90% of the tetramers are stabilized with the 80 milligrams without causing serious side effects or adverse outcomes compared to the 20 milligrams, and you get a more benefit with more stabilization for the cardiac function. And the trial length was up to 6 years, the long-term extended form. The initial trial was 30 months, 2.5 years, and the extension was up to 6 years. Choosing those time for the trial is because the median survival, as we said, in the untreated cases was between 3 and 4 years. So of course, you need to give the trial the first analysis at 30 months and then the long-term analysis at 72 months or 6 years. You got the patients were divided 2-1-2. 2 to the tafamidis 80, 1 to the tafamidis 20, and 2 to the placebo, which took the original medications for whatever condition, excluding tafamidis. The primary outcome was the composite endpoint of cardiovascular morbidity, mortality, hospitalization, and the secondary endpoints were the individual points of the primary endpoint plus the change from baseline to month 30 in the 6-minute walk test and in the Kansas City questionnaire score for the heart failure symptoms. Of course, the patients were matching regarding the baseline clinical characteristics. And I want to demonstrate that I said in the first lecture, whether you are cardiac amyloidosis, the hereditary type or the wild type, it does not matter because in both cases, as we will see going on, that the drug was effective. The hereditary type is important because you will do some genetic studies and tests to detect the individuals that will develop cardiac amyloidosis earlier enough so you can start the medication when they are still not heart failure and still before getting to NIHA 1 and NIHA 2, because those patients get the maximum benefit of survival, because the medication works to stabilize the transthyretin circulating in the blood and produced by the liver, but it does not affect the transthyretin that is already deposited in the heart. So the earlier the diagnosis of such a case and the earlier you will administer the medication, the more protection you will get against deposition of this amyloid material in the heart of the patient. The NIHA classes were presented. Most of the patients were NIHA 2, some of the patients were NIHA 3, and a fewer patients were NIHA 1. And let's see the results. The primary endpoint was 71% in the patient receiving tafamidis and 57% in the placebo. At month 30, hospitalization was 30% in the patient with tafamidis and 46% in the patient with placebo, which means that you get an individual relative risk reduction of 30% regarding the primary endpoint, mortality versus placebo, and number needed to treat was 7.5 patients, nearly 8 patients. You mean you administer the medication to 8 patients and you save 1 life. This is at as early as 30 months of administration of the drug. Whether the patient was a wild type or whether the patient was the hereditary type, the relative risk reduction was 29 and 31%, nearly 30% relative risk reduction, whether the patient is the wild type or is the hereditary type. But if you look at the patients who presented with NIHA class 1 versus NIHA class 3, for example, you will find that the reduction in the risk of death is nearly 64.4 in NIHA class 1 versus 16.3 in NIHA class 3. This means that you can save more than 2/3 of the patients with NIHA class 1, while you can only save 1/6 of the patient in NIHA class 3. And this highlights the importance of early diagnosis and treatment in those cases. Cardiovascular hospitalization was also reduced with a relative risk reduction of 32%, and patient years of treatment needed, approximately 4 patient years of treatment to prevent 1 cardiovascular related hospitalization. Regarding symptomatology, significant effect of symptomatology. At 30 months, the 6-minute walk test was improved by 76 meters, and the Kansas City questionnaire score was improved by 14 points difference for heart failure symptoms in those patients. After the 30 months were finished, the patients were included in the trial for the long-term follow-up up to 72 months, 6 years of follow-up. And what did we find? We find that the relative risk reduction at month 72 was 41%. And this showed that those patients who were receiving the tafamidis prolonged survival up to 6 years with a relative risk reduction of 41%. And this showed that those patients have still improving relative risk reduction of mortality, and this proves that the drug needs to be taken for a lifelong medication, as we said, so it can stabilize all the transthyretin tetramers produced by the liver. Symptomatology was improved, as we said, in NIHA class 1 and 2. The mortality was improved 44% versus NIHA class 3, 35%. And this shows you that the earlier you start the medication, when the patient is still NIHA 1 and NIHA 2, at 60 months, 5 years, you get a 44% relative risk reduction in those patients. Whether the patient was hereditary type, whether the patient was wild type, the long-term relative risk reduction was there with 39 and 43%. Comparing it to the regular 20 milligram, the tafamidis 80, tafamidis meglumine 80, compared to the tafamidis meglumine 20 used for those with peripheral neuropathy, the safety profile was the same. The serious adverse events were the same. And this showed that there is no safety concern regarding the higher dose of 80 milligrams. But actually, you get the benefit of what? You get the benefit of more stabilization up to more than 90% of the tetramers produced by the liver. So actually the benefit, or the drug starts working as early as 1 month. You get stabilization under the microscope. At 6 months, you get improvement in the 6-minute walk test, and you get improvement in the Kansas City questionnaire score. And at 12 months, you get reduction in the N-terminal pro-BNP. At 30 months, you get a 30% relative risk reduction of the primary endpoint. And at 72 months, you get a 41% relative risk reduction of the primary endpoint, which means that you can continue, and you need to continue this medication for life. Thank you so much, and see you in another lectures. Bye-bye.